senior professionals. In the next few minutes, I would like to talk on tailoring the SGLT2 therapy when empagliflozin is the better bet, how the empagliflozin scores over the other SGLT2 inhibitors as far as the medical management of our type 2 diabetes is concerned. We all know that diabetes is a very asymptomatic disease in most of the individuals, and we have to treat the diabetes in a very aggressive way just to prevent the long-term complications. You all know that what you mean by the long-term complications. If you see the eye, we always think of the retinopathy, either non-proliferative diabetic retinopathy or the proliferative diabetic retinopathy. And other than the retinopathy, we also have the premature cataracts in the uncontrolled diabetic individuals, and the glaucoma. The incidence of the glaucoma is very high in the diabetic individuals, and also the diabetic macular edema, which may lead to the diminution of the vision or the sudden loss of the vision also. So these are all the ocular complications because of the uncontrolled diabetes. As far as the renal is concerned, we always thought that diabetic kidney disease or the CKD is the most important complications in the diabetes. Other than that, a simple proteinuria and also a increased frequency of the urinary tract infections, maybe a simple cystitis or urethritis, and unfortunately in uncontrolled diabetes, ascending UTI is very common, leads to the pyelonephritis. Sometimes we have to sacrifice the kidney, so we have to post it for the nephrectomy in all these ascending pyelonephritis in uncontrolled diabetic individuals. As far as the heart is concerned, we all know that myocardial infarction is equivalent to the type 2 diabetes, and other than the myocardial infarction, and heart failures are also very common in diabetic individuals. Arrhythmias are very common, and also the peripheral vascular diseases, and also the cerebrovascular diseases like either ischemic strokes or hemorrhagic strokes or Alzheimer's or Parkinson's, multilacular infarcts, etc. As far as the foot is concerned, we are very much worried about the foot ulcers because the commonest cause for the amputation. And other than the foot ulcers, Charcot's arthropathy is also very common in uncontrolled diabetic individuals. That means a auto-digestion of the bones in the foot, and there will be the walking problems in diabetic foot diseases, and obviously they need offloading and sometimes the amputations also. And pregnancy, we all know there are the neonatal complications and maternal and the maternal complications. And when we are treating the diabetes in the pregnancy, we are treating in the 2 generations, because the mother who got the GDM and also the offspring who born to the gestational mother are both at the risk of getting the future type 2 diabetes and also the future metabolic syndrome. So with this background, we all want to reduce the complications of the diabetes or no complications of the diabetes in most of our diabetic individuals, how it is possible. So we have to concentrate on the cardio-renal metabolic trifecta. So whenever you treat a diabetes, you please see that the heart should be normal, the kidney should be normal, not only your carbohydrate metabolism, a pan-metabolic disorder disease. That means carbohydrate, protein, and the fat metabolism defects will be there. That also have to be corrected in all our diabetic individuals to have a good quality of the life. So this is the cardio-renal metabolic interactions in type 2 diabetes. If you see the background as an hyperglycemia, you all know that insulin resistance is very common in our Indian diabetics when compared to the insulin deficiency. So because of this insulin resistance, you will have the oxidative stress, advanced glycation end products, albuminuria, etc. That will lead to the neurohormonal and inflammatory response. So diabetes is a big inflammatory disease, not that it is an infective disease, but because of your vascular inflammation. So you'll have the interleukins and tumor necrosis factors, etc. They will be multiplied in the presence of uncontrolled diabetes. All will lead to either heart failure or the chronic kidney disease because of the increased cardiac congestion and the renal congestion, and because of the reduced cardiac output and reduced renal function. So finally there will be the fluid overload, and it's a bidirectional and lead to either heart failure or CKD. Unfortunately, in some individuals, both heart failure and CKD. So this is all because of the uncontrolled diabetes, uncontrolled hyperglycemia, and more insulin resistance. See, the people with type 2 diabetes are at increased risk of developing the heart failure. So how often it is the risk of developing the heart failure is more than the doubled versus those without the diabetes. So this heart failure is a very common diagnosis in our OPD or in our casualties or in the emergency departments because of the age. Now age is very common factor to cause the heart failure. So most of the people are elderly. Unfortunately, India's geriatric population is also very high. The people more than the 70, more than the 80 is also increasing like anything in Indian population because of the different interventions at different stages. Thanks to our interventional cardiologists or the nephrologists or the dialysis procedures, etc. More and more diabetics are living longer period to get the heart failure at the end of the story. In the same way, hypertensive heart disease, again a risk factor for the heart failure. Hypercholesterolemia, so more triglycerides, more LDL, low HDL, again will lead to the heart failure. And most important cause is the coronary artery disease. So post PTCA, post CABG people, after 5 years or the 10 years or the 15 years, they start developing the pedal edema, start having the orthopnea, PND, etc. And obviously the diagnosis is heart failure with your systolic function, EF less than 40 or less than 30, less than 20. Yesterday I have seen one fellow with a syncope, a diabetic, and also an alcoholic syncope. When you evaluated the syncope, his EF is just 28%. So this syncope is because of the heart failure and the rhythm abnormality. So we referred him to an electrophysiologist and he advised CRT therapy, which is costing about 15 to 20 lakhs. So fortunately, it's affordable, and in the next week we are going to go do it a CRT in that fellow. See, this is all because of the uncontrolled diabetes and excess alcoholism in that particular gentleman. So these are very common. Heart failure is a very common disease in our society, and the three common factors to cause the heart failure are coronary disease, the number one, number two is uncontrolled hypertension, number three is uncontrolled diabetes, and of course age is a non-modifiable risk factor. Type 2 diabetes is the leading cause of the CKD, and we also call it as an ESRD when the GFR is less than 15, where we have only two options for the ESRD, either the dialysis or the transplantation. See, 1 in 3 adults with the diabetes have the CKD, and the population is also the tenfold or greater increase in all-cause mortality compared to the type 2 diabetes alone. So once the fellow's creatinine is going up, so definitely there is a more risk of having the mortality, because either because of the nephrological or because of the cardiovascular. And unfortunately, most of the nephrological cases die in the hands of the cardiologist because of the premature atherosclerosis and early myocardial infarction and arrhythmias. See the estimated GFR less than 60 for at least 3 months to call it as a CKD. So a definition of CKD is either the structural defect or the functional defect. Structural defect means more and more proteinuria, and the functional defect means more and more creatinine. So when the fellow is having the increased creatinine more than the one for more than the 3 months, or your microalbuminuria more than the 30, or the USCR more than the 30 for more than the 3 months, so that is a structural defect. Either or both is a definition for your CKD, and unfortunately 80 to 90% of our type 2 diabetics are proteinuric, and also creatinine level is 1.2 or 1.3 or 1.6, etc. is very common in our society to call them as the CKD. Once the diagnosis is CKD means, so it is a very problematic disease, and we have to treat them as a special cases. Otherwise, these people will die prematurely because of the different causes. Understanding of the cardiometabolic interaction in the treatment of the type 2 diabetes management towards the organocentric pathway. See, let us see. In the 2019, so our thought was in all the type 2 diabetics, control the blood sugars, control the fasting, control the PP, control the A1C. That means our target is just control the blood sugars. So at that time, HbA1c, that is the 3 months average of your blood sugar, should be around 6.5. And the lower the blood sugar, the better the values or the better the outcome. So that was our thought in 2009. In 2015, we also thought that the diabetes control is very good. Hyperglycemia management should be as good as keeping the HbA1c around 6.5. But now, the lower the blood sugar is good, the better the outcome, but not at the cost of hypoglycemia or the weight gain. So hypoglycemia is very dangerous in all the diabetic individuals, and weight gain is also more dangerous because more and more weight gain means more BMI, and more BMI will lead to a lot of the malignancies and early atherosclerosis, early osteoarthritis, GERD, obstructive sleep apnea, sleep disturbances, etc. So in 2015, we thought that you keep the HbA1c at 6.5. So the lower the blood sugar is good, better the outcome, but don't allow any diabetic individuals to get the hypoglycemia or increased body weight. And then 2018, so we thought that simple correction of the blood sugar is not sufficient. we have to give a lot of respect to the heart and the kidney. So cardiorenal events. So earlier the story between 2015 and 2018 is introduction of your rosiglitazone drug. After the initiation of the rosiglitazone, a lot of the people that died prematurely because of the cardiac events. So then we thought that in all the diabetic individuals, along with your blood sugars, please concentrate the heart also. So along with the heart, kidneys also. So the cardiorenal events were given a very priority in 2018 onwards. And I always say several times to you that ABC is very important. That means A1C control is your diabetes control. B is for blood pressure control. C is for cholesterol control. So that's what 2018 onwards we say that blood pressure control, lipoprotein control, glucose control with proven safety and efficacy. And then now we are in the 2025. So what is the concept now? The concept now is prevent the complications, give quality of the life. So all these are goals good. HbA1c control is good, lower is the good, better outcome is the good, and also hypoglycemia, no hypoglycemia is the good, no weight gain is the good. At the same time, the blood pressure has to be kept between 120 and 130 systolic and diastolic 80 to 85. And also the LDL less than 55 or the 30, and then the HDL around 40 or more than the 50. These are all very, very good. But now all plus quality of the life is very, very important. All the diabetic individuals, and also prevent the complications. Even though the fellow is having one complication like diabetic foot ulcers, don't be unhappy. See him not to have the IHD, not to have the CV, etc. Suppose the patient is shifted from the ICU with a diagnosis of the acute myocardial infarction. Still don't worry. So please treat him not to have the future CVS or future diabetic foot ulcers or future infections, etc. So now the concept of the 2015 diabetes management is control the blood sugars, control the blood pressure, control the cholesterol, and also give good quality of the life and prevent the complications. What are all your micro or macrovascular complications or complications peculiar to the diabetics in Indian population? See, in COVID, we see a lot of the mucormycosis is a very, very common in uncontrolled diabetic individuals. Sepsis is very common in diabetic individuals. That are the people, the important mortality cause in COVID is uncontrolled diabetes. So the diabetes in India is more challenging. In India, the condition was worsened than the earlier expected. So now we have a lot of the doctors, good knowledge, good medications, good insulin, still lot of the medical colleges, but still the control of the diabetes is not that to the optimum levels. See, if you see the International Diabetes Federation, IDF, headquarters is not at the India. So somewhere outside the India, they thought that in 2021, there will be 74 million people with the diabetes in India and the prevalence rate is 10.4%. But what is the exact figures? Exact figures from the ICMR, India study is nearly 2020, same year, we have the 10 crores diabetics. So outside the India, their production is 7.5 crores, but our reality is nearly the 10 crores in 2021. Today, I thought that nearly 12.5 to 13 crores of Indians are the type 2 diabetics. Now the prevalence is 11.4%. This prevalence is increasing in the cities. So the city with the highest prevalence in India is Hyderabad with about 26%. So most of the Hyderabad people between the 18 to 70 years of age group are the diabetics because of several reasons, and two important causes are the biryani and bakery, Karachi bakery and Paradise biryani. So the main challenges posed by the type 2 diabetes management in India, compliance. We all know that compliance is a very, very poor in both urban and the rural, educated, uneducated, doctors, non-doctors. So the compliance and the therapeutic adherence is very, very, very poor. Achieved the target and the durable glycemic control. We always thought that no, the sugar is 80 or 90, 100 is okay. But if you check the HbA1c, that is 8 or 9 or 9.5. So that is not good. And then diabetes complications such as cardiovascular, renal complications. We never thought of the getting or noting the complications at an earlier time. What I mean to say is renal complication. What is the renal complication of the diabetes? UTI, uncontrolled UTI, or diabetic nephropathy, or the nephropathy, that is the microalbuminuria. So simple urine microalbuminuria costing about 250 to 300 rupees is sufficient to know whether the fellow is having the renal microalbuminuria or not. In the same way, urinary albumin creatine ratio. So that is costs about 200 to 300 rupees. Or 24 hours urine protein. So how many of our diabetics are getting these to know the early onset of the diabetic nephropathy? In the same way, the heart. So one has to get the ECG, one has to get the 2D echo, and then the TMT, and also sometimes no serum, calcium score, coronary calcium score. And of course, some people, they may require the coronary angio also, provided if the chest pain is typical of angina or angina equivalent. So one need a coronary angio also, because even though the blood sugar is normal, blood pressure is normal, ECG is normal, 2D echo is normal, TMT is negative, still if you get the CAG, so the patient may have the person, sorry, we should not call the diabetic as a patient. A person may have a triple vessel disease and need emergency CABG also. So all investigations are very, very important in all the diabetic individuals. It is up to you to decide what to do, what not to do. See, and many more. A lot of the challenges are there in type 2 diabetes management in India. Status of the medication. And today I have seen one patient with blood sugar 578. I told her, admit, and also had a lot of ulcer, big ulcer on the left foot. I told that woman to get admitted and give, and I would like to give you a good insulin management. I would like to give you a good antibiotic coverage. I would like to give you the good amount of the statins and also the celastazole, etc., etc. Let me give 1 hour time, doctor. After 1 hour time, she asked some more one more hour. And after getting a lot of the calls from his sons, daughters, etc., and etc., she left the hospital without joining. See what will happen tomorrow or day after tomorrow for her. She is aged about 45 years. Imagine, with the blood sugars of that much, 500 plus, and ketone body is positive, and the creatinine level is 2.5, SGVT is SGOT are 90, and the ECG shows LVH. Imagine the future of her. I totally unhappy with her. Every day I have seen such cases. In spite of our a lot of the exposure or experience in our management of the diabetes, even though we are very down to the earth with the public, with the patient, but still the people are not listening our words and not admitting in any hospital. See, that is the scenario. So that is very biggest challenge in our management of the diabetes is the people are not hearing the doctor's advice for several reasons. See, study from the Bangalore, a non-adherence to the anti-diabetic medication was 21% in Bangalore. So we thought that Bangalore is a very educated place, but still 21% non-adherence. Uttarakhand, about 56% had poor adherence. And whatever the Mangalore, supposedly one of the best medical colleges are there, the best private medical college in India is at Mangalore. But still, 49% of the patients were found to be having poor medication adherence. See, this is the scenario in our Indian population. In Punjab, only 32% of the patients strictly followed their anti-diabetic medication regimen. That means nearly 68% they are not listening the and they are not following the adherence. So this is the scenario. If you see the Kakinada, I think maybe 25 to 30%. So one of the key factors affecting the medication adherence is the polypharmacy and swallowing difficulty because of the size of the tablets. See, some tablets are very, very big in size, and there is definitely a swallowing difficulty. So reasons for the non-adherence, a costly medical problem. So the most costliest medical problem is non-adherence, not the cost of the tablets or the injections, but non-adherence because of several characteristics of the disease. See, why the non-adherence? Because type 2 diabetes is an asymptomatic disease. See, it's very difficult to convince the fellow who is an asymptomatic to get the medication for the lifetime. So we have to tell all the etiology of the diabetes and the duration of the diabetic medication and what causes if they are left untreated, what are the other complications, etc. So this is the characteristic of the disease. So sometimes medication of the side effects. So the better interest, if you start with the metformin, all people say that metformin is the initial agent to be started, and immediately if you start the metformin, these people will have the nausea, vomiting, cramps, etc. In an asymptomatic fellow, having convinced that the diabetes is the medication is needed, but is that all? Suppose if you started with the glimepiride, maybe 0.5 mg or 1 mg, so they get the severe hypoglycemia if the lunch or the dinner is delayed. Suppose if you started in the pioglitazone, so pedal edema, etc. You started on the oglibose, so again the gastrointestinal side effects. You started on the gliptins, so maybe the nausea, vomiting, or upper respiratory tract like infections, and sometimes in a chronic alcoholics, maybe pancreatitis like picture. if you started an SGLT2 inhibitors, so the people may develop the urinary tract infections or the monilial infections or dehydration or polyuria, nocturia, etc. So every drug will have a side effect. So unfortunately, some of the people know, even though you start all these drugs, every complication or every side effect will be seen in that particular individual. So the only drug left for us is the insulin. Again, insulin will cause hypoglycemia. Again, insulin will cause maybe hypodystrophy or hyperdystrophy, etc., etc. So the side effects is also a big problem. But fortunately, 99.9% you don't have any much side effects in most of our individuals. But you should know what are all the side effects. Formulation design is very important. Duration of the treatment, most probably lifelong. But now the reversal of the diabetes is true. It's possible. Reversal of the diabetes in all elderly population, in very obese individuals, those who are very compliant to the medication. So reversal is possible. Frequency of the expected intake, complexity, that is the polypharmacy, and severity of the disease. So the more the severe, you have to prescribe the more the drugs. Again, the comorbidities are high. Suppose the person is also a diabetic, hypertensive, dyslipidemia, or past history of the IHD, or past history of the diabetic foot ulcers. You need a lot of the medications. See the patient-centric outcome. See the size of the tablets. So it's very, very difficult to convince the fellow to take these tablets every day. So achieving the target glycemic Indian scenario, glycemic control is poor in Indian diabetic patients with a mean HbA1c of 8.9%. So our A1C, earlier it was 9.3. Unfortunately, because of our CM is different, CM is all over India. So our A1C has reduced from the 9.3 earlier to the 8.9. So still 8.9 is much higher. So a lot to be done to reach 6.5. I hope that in Kakinada, all our diabetics will have the HbA1c of 6.5 or less because of your good knowledge on the diabetes. Only 19, nearly 20% of the Indian diabetic population achieve the HbA1c target of less than 7%. Only 20% are achieving this. 47% of the patients do not achieve the glycemic targets even after the dual or the triple drug therapy. So some people they may require 4 drugs, 4 OHS. Some people they require 5 OHS. Some people they may require OHA plus insulin also. Whatever may be the drugs number, etc. I always tell to my patients, don't count the number of the tablets or the number of the units of the insulin what you are getting it. Please consider the fasting blood sugar, postpone blood sugar. What is the fasting blood sugar? Is it around 100? What is the postpone blood sugar? Is it around 150? To reach that 100 and 150, even you take 200 units of the insulin or the 4 or the 5 tablets, nothing will happen because your heart will be good, your lungs will be good, your kidney will be good. So this is very important. But unfortunately, most of our Indians know, they think quite in a reverse direction. So they thought that I am taking 4 tablets, I am taking this much of the insulin, but still my blood sugars are very, very high. So always treat the blood sugars, not the count the numbers. See, this is the one Ernakulam district of the Kerala. So that is the, I think, finance capital of the Kerala, Ernakulam or the Cochin. See here, 83.6% are aware of the diagnosis of the diabetes. In Andhra, I think nearly 50% are aware of the diabetes. Still, a lot of the people, they don't know that what they mean by the diabetes. They're living without knowing that they are having the diabetes. And in Cochin, about 75% were being treated, whereas in Andhra, I think maybe 60 or 70% are taking, are getting the treatment. But finally, 40% are the control the blood sugar. That means 60% are not control the blood sugars, even in the one of the richest cities and the most highly educated, 100% literacy rate in Ernakulam or the Cochin. So this is the results. You can imagine in what about the results in our Keralampudi or in Divili or in Rampachadavaram or in Samalkota. Okay, so a lot to be done. So it's our rule, our duty to identify the diabetes much early and tell all the history of the diabetes and give a good proper diagnosis so that a lot of these people will not have any complications. So the baseline data available from the Achieve study found high prevalence of the diabetic microvascular as well as the macrovascular complications. Both the retinopathy, nephropathy, neuropathy as the micro or coronary artery disease or cerebrovascular disease or peripheral vascular disease as a macro are very, very common in Indian population. See the neuropathy, nearly 25% are having tingling, numbness sensations. See the neuropathy here, you all think that is only sensory neuropathy. Some people may have the motor neuropathy. So they are very comfortable in the standing position. But once they sit down, so it's very difficult to get up because of the thigh muscle weakness. So that is called as proximal myopathy. So that is also compared as a motor neuropathy. And some people will have the autonomic neuropathy like this postural hypertension. Some people will have resting tachycardia. Even on the rest, their heart rate is 120 or 130. So that is cardiac autonomic neuropathy. Some people will have alternate constipation and the diarrhea. So Monday and Tuesday constipation and Friday and Saturday diarrhea. So this is also because of the gastrointestinal autonomic neuropathy. Some people will have the profuse sweating. Some people will have the dry skin. So these are all the features of the autonomic dysfunction. It is very easy to diagnose, but no treatment. Very, very difficult. Main the treatment is control the blood sugar. Control the blood sugar. Even with the intensive insulin therapy, now I am keeping him on the fasting 30 units before the breakfast, 40 units before the lunch, 30 units before the dinner, and I am giving the Tresiba, the glutec, at about 60 units at the bedtime, and making the fasting blood sugar 104, pre-lunch about 130, and post pre-dinner about 120. I am very happy with the control of the diabetes, but I am not getting any result about the postural hypertension. So the only thing is stockings. So they are also not helping him. See, there are a lot of the unfortunate individuals in India, even though they are affordable, they are rich, we are not able to do anything for them because of these different complications. See, the neuropathy is also very, very common, and you all know that the simple tingling and the numbness, for that also the treatment is very, very vague in most individuals. So some people, they are very happy with the pregabalin, other fellow, they will have the giddiness with the pregabalin or the pedal edema, etc. Some people will be very happy with the nortriptyline for 1 day or 2 days, and then they will have the nausea, vomiting, dizziness, etc. See, the gabapentin, the same thing will happen to them. Tryptomer, we start the 10 mg, and then some people, they take the 25 mg BD, TAD, etc. Again, they may not have any good response. And methylcobalamin or ALA, etc., etc. Even the tons of the methylcobalamin give, they are not of much use. So the neuropathy is a very secret symptoms. So some people have the erectile dysfunction, even at the age of 20 years, 35 years, 30 years. So it's very, very difficult for them to treat that condition. So we need sometimes the help of the SVS Rao garu to tackle these secret complications of these neuropathies. And of course, coronary artery disease is a very, very common. The commonest cause of the death is diabetes. Sometimes, you may be surprised that in the cardiac ICU, the one drug which is common for the 15-bedded ICU or 20-bedded ICU is the insulin. That means all the fellows are the diabetics in the cardiac ICU sometimes. The same thing happens in the neuro ICU also. See the nephropathy. Yes, now the cardiologist and the nephrologist, the bread and butter is the diabetes, uncontrolled diabetes. Uncontrolled and chronic diabetes. And retinopathy. Again, the retina surgeons are there now. Earlier, we have very few retina surgeons in Andhra Pradesh. Now, fortunately, we have the 2 or the 3 retinal surgeons in every place. Again, the bread and butter for the retina surgeons is again diabetic retinopathy. See the image. So don't think that diabetes is a simple disease. The diabetes is very simple, but the complications are very costly. So don't allow these people to have these complications. So the role in the cardiometabolic pathway. So they improve the glucose control in the type 2 diabetes. Very, very good drugs, SGLT inhibitors, because they act peripherally. They never touches the beta blockers. They never touches the beta cells. They never touches the pancreas to release more and more insulin so that the people will have the hypoglycemia. These SGLT inhibitors, they act peripherally at the level of the kidneys only. You see the picture here, that is the glomerulus, and then that is the proximal convoluted tubule, and then the loop of the Henle, and the distal convoluted tubule, etc. These drugs will act on the proximal convoluted tubule only. Whatever the glucose is there, the glucose will be filtered 24 hours, 24/7. All the filtered glucose will be again reabsorbed through the proximal convoluted tubule. That is the reason we are not having the glucosuria. Okay, but while prescribing these drugs, SGLT inhibitors, you are making the reabsorption of the filtered glucose is blocked. So what happens after filtered the glucose in the glomerulus? Because of the no reabsorption, all the glucose will be carried to the loop of the Henle, distal convoluted tubule, and finally to the urethra. So all the urethra is filled with a lot of the glucose. So that is the concept of these SGLT inhibitors. So because they will have the diuresis, along with the glucose, there will be the sodium loss is also there. So there will be the natriuresis, and there will be the glucosuria because of 4 plus glucose, and then there will be the uricosuriya also. So that the blood pressure will be reduced because of the sodium excretion. The arterial stiffness will be reduced, and there will the volume of the blood will be reduced because you are causing the polyuria, glucosuria, and natriuria. and then there will be the glucose toxicity will be reduced and insulin resistance will be reduced. So these are all the advantages of these SGLT inhibitors. See the mechanism of the action of the SGLT inhibitors already I told you. So finally there will be increase in hematocrit. So that means the PCB will be increased because of the loss of the plasma or the fluid. Weight loss will be there. So these people will have a 2 to 3 kgs or the 4 kgs weight loss with the SGLT inhibitors. That is very, very good in diabetic individuals, because just 1 kg weight loss will give you about 2 to 3 millimeters mercury reduction in your blood pressure, and there will be some reduction in your lipids, there will be some reduction in your body weight, etc. And improved ventricular loading conditions, because it reduces the preload and also reduces the afterload. So the LVH will be reduced, and finally you will have a good cardiac protection. So SGLT inhibitors block the SGLT2 dependent glucose and the sodium receptor reabsorption in the kidneys. So what are the recommendations? See the 2030 European Society Class 1 Level A. So this is your EMPA or the CAN or the DAPA. These are the SGLT inhibitors. They are recommended in patients with the type 2 diabetes, multiple atherosclerotic cardiovascular risk factors or established atherosclerotic cardiovascular disease. In the same way, heart failure with reduced ejection fraction, and also heart failure presentations, and also CKD population. So SGLT inhibitors are very, very useful drugs in these high-risk individuals, high-risk diabetic individuals. See, KDIGO 2022 recommendations for the CKD and the type 2 diabetes. Lifestyle therapy is very important. Your physical activity, nutrition, weight loss. And the first line therapy, metformin. Again, respect the GFR. According to the GFR, you have to give the doses of the metformin. And SGLT inhibitors also according to your GFR. And if you are not able to give the metformin and the SGLT inhibitors because of the elevated creatine and reduced GFR, and then you can go for the GLP-1 receptors or the inhibitors or the insulin or sulfonylureas, etc. So this is the recent guidelines, 2025. They say that whenever you see a diabetic, whenever a diabetic sitting in front of you, you see that whether the fellow is at risk of heart failure or not, give SGLT inhibitors. If the fellow is at risk of hitting the CKD, again give the SGLT inhibitors. Whether the fellow is at risk of atherosclerotic cardiovascular disease because of the obesity, because of the smoking, because of the strong family history, or because of the uncontrolled diabetes, hypertension, dyslipidemia, so this fellow is at high risk of getting the atherosclerotic cardiovascular disease. Here the cardiovascular disease means a broad word. So cardiovascular disease includes ischemic heart disease, cerebrovascular disease, and peripheral vascular disease. Again give the SGLT inhibitors. So unfortunately, 80 to 90% of diabetic individuals in our society, they fall in these groups. Most of those people are at high risk of atherosclerotic cardiovascular disease. Most of the people are at risk of CKD, and most of the people, especially elderly population, diabetics, are at risk of heart failure. So there is always a scope to use SGLT inhibitors in them. So what are the landmark trials? So these are the lot of the landmark trials. We have the 3 SGLT inhibitors, dapagliflozin, so DECLARE-TV, and then the empagliflozin, EMPA-REC outcomes, and canagliflozin. So that is the CANVAS study. But we are not using the canagliflozin right now in India because of the fear of the 2 reasons. One is the peripheral vascular disease, and then the Forener's gangrene. So we are using either DAPA or the EMPA. So these are the cardiorenal studies. You have the CREDENCE study, DAPA CKD, EMPA CKD, delivery, etc. So these studies, renal trials, heart failure trials, these are the lot of the trials are there. Let us see how the most common SGLT inhibitors compare to each other. So this is a very important slide. Show you the differences between the dapagliflozin and the empagliflozin. If you see the selectivity of your SGLT2 inhibitors, dapagliflozin is about 1200-fold, whereas the EMPA is nearly the double, 2500-fold. The dosage of the DAPA, either 5 or the 10. 10 mg is the maximum dose. Unfortunately, a lot of the people they are using 10 mg BD. 10 mg plus metformin 500 is available. They are taking the BD. Don't give the BD of the dapagliflozin. OD only, that to 10 mg is sufficient. Empagliflozin, we have the 2 strands, 10 mg and the 25 mg. So now either 10 or 25. Earlier, 25 mg, 10 mg is about 80 rupees, 25 mg is about 80 rupees, same price. So our people are very clever. They bought the 25 mg at 80 rupees and scored off tablet. Okay. They made 40 mg, 40 rupees for the 12.5 mgs. Now this is the molecular comparison. So DAPA, this already I told you. So the clinical trials about the dapagliflozin and the empagliflozin. So they say that EMPA results in about 14% relative risk reductions versus the 7% in the dapagliflozin. See the diabetes, hypertension, the CKD, again EMPA results in about 25% versus the 26% reduction in the dapagliflozin. Heart failures with reduced ejection fraction in the CKD. Even EMPA can be used as low as the 20 GFR versus the 25 in case of the dapagliflozin. It's a very minimal variation. In both these conditions, you can use either DAPA or the empagliflozin. EMPA reduces the HbA1c nearly 29% more compared to the DAPA. That is the most important take-home point. So as far as the HbA1c reduction is concerned, more with the empagliflozin when compared to the dapagliflozin. So in patients uncontrolled on the metformin, the imipenem, and the gliptins, that's what commonly we use these three drugs. EMPA is more efficacious, especially with its ability to beneficially regulate the cardiometabolic parameters without any adverse events. So I have seen the SGLT inhibitors like EMPA inhibitors role in the cardiometabolic therapy. Now to address the medication adherence. So tablet size matters a lot, shape, other physical attributes are also good. So tablet coating technology is also important. A fear of choking or gagging, we have to avoid them. So this is the slippery method. So that's what happened in this recent EMPA XL. So you will have just once a coating technology will reduce the side effects like the choking perception during the tablet ingestion and improved compliance. So in conclusion, people with type 2 diabetes are at increased risk of developing the heart failure, CKD, IHD, and all complications. SGLT inhibitors have the cardioprotective effects. I have shown you different slides showing how they improve the cardioprotective effects, reduce the hospitalization of the heart failures and severe mortality. They provide the renal protection and reduce the risk of the kidney failure in people with the type 2 diabetes. Adherence and the durable glycemic control is very, very important. EMPA can provide a durable cardiometabolic control. DAPA and EMPA, but in high-risk patients and patients with the type 2 diabetes and established CV disease, empagliflozin provides the better risk reduction when compared to the dapagliflozin. And pill innovations also makes a lot of difference as far as the compliance is concerned. So thank you very much for your patient hearing, and I will be happy if you have any questions.